Welcome to the Practicing with Dr. Nathan Goodyear podcast. I'm the medical director at Brio Medical in Scottsdale, Arizona. I am both a conventionally trained and licensed medical doctor as well as a licensed medical homeopathic doctor. This podcast is your resource for a scientific-based discussion of all things cancer and beyond from a natural, holistic, and integrative perspective. It's time to teach the body how to heal. So here we go. Welcome back to another Practicing with Dr. Nathan Goodyear podcast. We're going back to bring somebody to the future here with us that we recorded a few podcasts with back in, I think it was late fall, early in the summertime. Dr. Jason Williams. He's got a clinic down in Cabo where he is actually revolutionizing how we approach cancer. And so if you want to check those podcasts out, I encourage you to go back and check those out. And we'll give him to give you his contact information at the end of this podcast. But how I want to start this out, and then we'll bring Dr. Williams in, is I want to really provide some context here. Kind of tee this up for Dr. Williams. One of my favorite movies, of course I'm a guy, but one of my favorite movies is that Russell Crowe movie, Master and Commander. And I know Dr. Williams likes to do some things with boats as well, but there's a famous quote in there that says, "Sir, might we press you for an antidote?" And what we're going to be doing here is Dr. Williams is going to be bringing forth, if you will, a few antidotes, a few case studies. And when you look at that word antidote, it's a really interesting word. It's a short narrative or an interesting amusing. It's basically secret or private stories, things unpublished, things unknown to the general public. That's exactly what Dr. Williams is going to be bringing to you today on the Practicing with Dr. Nathan Goodyear podcast. Jason, man, it's good to see you.
Nathan, always good to see you. Gosh, we sat next to each other in medical school.
I know. So
it's amazing.
Yeah, it's, I think back to those times, and I think we look better today than we did then. Of course, don't you?
Probably do.
Yeah.
Probably do.
And in fact, it's going back so far, it's hard to remember what we even looked like. But, back then when we were in medical school, Jason, we were sitting there for 8 hours on end?
Oh, gosh, yeah. It was grueling, but, it was a good experience. Glad we did it, but glad we don't have to do it again.
Oh, isn't that true? You remember microbiology? Oh, my God.
Oh, yeah.
Gosh, yeah. They gave us the box of papers. I mean, it was just incredible. So, but anyways.
Yeah. It was, I had studied almost graduate level biochemistry before I even got to medical school. They blew through everything I knew in 2 weeks. So I was like, my gosh, the pace was so intense.
Oh yeah, it was nonstop, and you kind of look back on that. Honestly, right now, look back on it with fond memories. I think right after it was kind of PTSD, but right. Now with time, I think that started to heal a little bit. You and I were talking before we jumped on here, Jason, and when I talk to patients about fecal transplant, because that's the overarching theme of this podcast right here with you. Most people, when I talk to them about that, the look in their eyes is one of just absolute confusion and bewilderment. I can't imagine what's going through their head, but when I mention it to them, fecal transplant, they're clueless. Have you seen that when you've talked to patients?
Yeah, I think unfortunately the patients don't understand how important the gut microbiome is in relation to cancer. And, and this is, I think, one of the reasons we're seeing such a high incidence of cancer nowadays is because of the insult on the gut microbiome, disrupting the microbiome. And, what normally happens is the bacteria are in there and they actually are working symbiotically with your body. They're producing substances that end up doing things to your immune system, right? And help your immune system know to attack cancer or do other things. And they've even seen in mice, if you take gut microbiome from an older mouse and put it in a younger mouse, it makes the mouse behave younger. So you can transfer those type of factors. And it's really interesting all the effects of the gut microbiome, and now, I think it's really starting to come to the forefront, and people are starting to understand it. And I think they're also, they're obviously they're wondering, like, gosh, why are all these young people getting cancer nowadays? It discussed like the plastics, microplastics. Obviously people weren't wondering about vaccines and things like that. But the other thing is the gut microbiome, and look at like what a lot of people are eating. And so there are certain things that really insult the microbiome, like stevia, like Splenda. Those things actually kill the microbiome, and so they make you more predisposed to cancer. And there is a guy at the University of University of California, San Diego, named Rob Knight. He almost won the Nobel Prize last year for his work in the microbiome, and he has a test where he can look at your gut microbiome, and he will tell you what cancer you have. So
what you have, or what you're at risk for, or both?
Or both, yeah. But he will pretty much tell you, like, so he has a test. It's called Microbiome, and so it's looking at lung nodules. And if the person has a lung nodule, he looks at the microbiome. He'll tell you if that lung nodule is cancerous or not, based on their microbiome.
Whoa!
Right. So that's exactly. So, yeah. So if you can tell somebody has cancer based on their microbiome, then what does that tell you, the influence of the microbiome on cancer? And so, to me, the majority of cancer patients have bad microbiomes. That's why they have cancer in the first place. I mean, there could be other issues, but that is certainly a foundation, a base. And so you have to fix that problem. And what I tell patients, if it's me, if I have cancer, the number one first thing I'm doing is trying to fix my microbiome and looking at something like a fecal transplant. And thankfully nowadays, though it is off-label, there is an FDA-approved fecal transplant called Rebyota. It is for C. difficile infection. So C. difficile obviously is a bacteria that people get when they take lots of antibiotics and kills off all your good bacteria. And then you get left with this, pathogenic bacteria. And then you can treat it with more antibiotics like oral vancomycin. But a lot of times that doesn't get rid of it. The patients have diarrhea. And so how do you fix it? You can reintroduce new bacteria. I think that first was done maybe in the early 80s, right? And so, I think there's probably stuff going back further, but, at least the stuff that I know going to the 80s. And so, the Rebyota, Ferring Pharmaceuticals, they developed this to treat C. difficile infection. The idea that, if the patients have been treated with antibiotics, you could do this fecal transplant. Now, I have had meetings with the people at Ferring Pharmaceuticals, and just so you know, I have no financial interest in Ferring Pharmaceuticals. I wish I did, because they have a good product, but I don't. They're a private company. And but the thing is that they I don't know how they make this, because it's like, is it a pooled donor? How do they get good donors? I mean,
Right.
How are you going to get consistency with that? I mean, for the FDA to approve something, it needs to be fairly consistent. I mean, you give a product today, you give it in a year, it should be the same. Now, how are you going to do that with donors unless, now this is the only thing, and I'll tell you, I met with very high up people at Ferring Pharmaceuticals, and what I learned is that their formula is like Coca-Cola. They don't know. I mean, even the people high up in there don't know how they make it. And so what I can imagine they do is that they studied and analyzed and pulled some really nice microbiomes that were ideal, and then maybe sort of simulated, cultured it, and grew it, and pull from it. That's what I would think, that they had to do something like that, but I don't exactly know for sure.
So basically, their formula's crap.
That's right. It is.
It's crap on both sides. It is crap, but it's crap. I don't know what it is.
But it's very good crap. That's good crap. So yeah, I mean, so what do we do with patients? So we've been knowing that, gosh, since 2015, there were studies showing that the microbiome was hugely important for the response to immunotherapy. And so we knew there were certain key bacteria. Bifido brevi, Bifido longum, Akkermansia mucophilia, Clostridium butyricum, fecal bacterium prosnati. Those are some top bacteria. There's a bunch of others. So you're looking at various ones, and sometimes it's you have you're lacking bacteria that you need. Sometimes you have certain bacteria that are there that you shouldn't have. So depending on the cancer, and some question, like for example pancreatic cancer, the patient's microbiomes are bad. Should we actually wipe out their microbiome and repopulate them a new microbiome?
Well, that's an interesting concept, Jason, because you're talking about, everybody talks about, bone marrow transplants, right? You've actually seen in the literature where they're actually, referring to fecal transplant in very similar language as you would in terms of grafting. It's like it's a transplant, and so that's a very interesting concept that you just proposed there.
Yeah. I mean, this is sort of the type of thing that we've been doing with the patients. And so what, for years, what do? We tried to give the patients the things that we knew helped their microbiome. So camu, which is a fruit from the Amazon rainforest, a lot of these good bacteria like polyphenols. So cranberry extract, things like that are all useful to help feed them, because one thing is having the bacteria, and the other is also what you feed them too. So you have the bacteria there, but then you also have to feed them appropriately, and then high fiber, fructooligosaccharides, inulin. Then there's this kiwi extract that they call Livox, which is helps increase fecal bacterium prosnati. These are, all like interesting things that we were trying to do. And then there was a company that came out with a supplement or a probiotic that has Akkermansia. For years, there was no way you couldn't take Akkermansia. If you either, for us, what we did, we would analyze the patient's microbiome. If the patients had Akkermansia, we said, okay, they could potentially respond. If they don't have Akkermansia, we're like, oh my gosh, they're probably not going to respond to immunotherapy. Their only option is the fecal transplant. So the only option we had was to try to get a donor and do it the old way. But then, this company called Pinium Life came out with this product of Akkermansia. They have one of Clostridium. And so, and interesting, I think I sent you that study a few days ago talking about the young patients, or all these young people getting colorectal cancer.
Yeah.
And then they were saying they're finding a high amount of Akkermansia in the tumors.
Yeah.
But those are the ones that are the good responders, right? So it's sort of a response to the problem that's trying to get rid of it. And this is really interesting. And but we looked at the idea, like, let's test the patient's microbiome. Let's see if we can figure out who's good, who's bad, who needs a fecal transplant, who doesn't, who can fix themselves with supplementation. If some people can fix themselves with supplementation a little bit, I mean, that's certainly at least the easiest option. But a lot of people can't. And so, but what we found was when we did the testing, this is what I did. I took the patients, and the patients who tested well, I didn't give them Rebyota. The patients who tested poorly, I gave them Rebyota. The patients that I gave Rebyota responded really well. The patients I didn't give Rebyota to didn't respond as well, and so some of those patients I then gave Rebyota, and then they responded. So that made me understand that our testing was not useful. We couldn't tell whose microbiomes were good or not. And some the studies indicate that when they looked at like taking these super responders, these people who respond really, really well to immunotherapy, and do a fecal transplant to somebody who's a non-responder, and a decent number of those patients didn't start to respond. However, they found if they took people who had really good microbiomes but didn't have cancer, it was even better, because the super responders had cancer. So they had cancer for a reason, because their microbiomes weren't as good. Their microbiomes may be better than others, but they weren't as good because they had cancer.
Wow. Well, we've sat here for about 15 minutes now talking about gut microbiome. So I wanted to define a few terms here to kind of help people provide the context before we start jumping into the process of fecal transplant, especially these anecdotes or case studies that you got here, which are pretty amazing. So first, I think it's understand there is a environment of bacteria, viruses, fungus that live with us and our cells. And the human microbiome is essentially the collective genomes and byproducts of all microorganisms. So this includes bacteria, viruses, and everything. And they inhabit the human body all over and are called the human microbiome. But now what Dr. Jason Williams has specifically been talking about quite readily is the gut microbiome. And what that is really the microbiome, the bacteria and viruses and other things. But here we're talking mostly about bacteria that are confined within the gut area there. And so when you were talking, Dr. Williams, about testing, is there a good test out there to help us to properly assess what that gut microbiome is like? Is there a good, reliable one clinically?
I'll be honest with you. I think, Nathan, unfortunately not. I mean, I think that you can look. So one, you could do a test like a commercially available in like Viome. Patients can go online and just order that themselves. And then you could go and look and say, okay, do I have Akkermansia? Do I have Clostridium butyricum? Do I have these bacteria that we need? But I don't think that tells us the full answer. And there's one thing. So you've got the diversity, lots of different types of bacteria, but then also you got the numbers. So you could have lots of different types of bacteria, but maybe you only have just a few Akkermansia or a few Clostridium. That's there, but it's little. So,
right.
But those people can be improved, but yeah, it's difficult. I mean, I think that there's some patients that maybe are fixable, but I think that some patients are not. And, a lot of times what I'm finding is that we're giving patients immunotherapy. These immunotherapies are super expensive. And Rebyota is expensive, but it's a good investment. And so I kind of feel like, instead of throwing, good money after bad, maybe it's just better just to give them Rebyota to try to fix them, so we're not messing around and wasting our time and say, well, let's do immunotherapy and it's not working. So we've, for the most part, started giving almost everybody Rebyota. And, there's, but otherwise, if you want to fix it, there was a recent study with, did you see the study from MD Anderson about navy beans?
I guess I did not see that one. What's
That's
that?
an interesting one. Yeah. Daily navy beans, improve the microbiome, improve survival in colorectal cancer patients.
Oh, wow.
And so, there's certain, food things that, I went and bought a bunch of navy beans. I haven't started cooking them all yet. But
in the Navy.
I think I will. Obviously, I like red beans and rice, from Louisiana.
Oh, yeah.
As you know.
Oh, yeah.
So, like the New Orleans food. But there's a great study on navy beans with that, and so it's really, really interesting.
Well, we'll have to put that. We'll have to find that. Send me that study, Jason, because we'll have to put that in the show notes so that they can get access to that.
I'll send it to you. Yeah. It's a good one.
Well, it's really interesting. We're talking about the gut microbiome. Like you said, the literature is really starting to blossom there in terms of really giving us not just the what, but also the how, showing that the gut microbiome plays a significant response to cancer treatment, susceptibility to toxic side effects from treatment, and that both affects the immune system locally, but then also systemically, which is the mind-blowing, and thus affecting inflammation and even metabolism of the tumor. So really the concept of the gut microbiome, and these studies will be in the show notes. And when you look at a lot of this literature, it's really recent, right? And so what's been your experience when you talk to our colleagues, other doctors out there? Are they right on board with this, or do they know about it?
Most of them are like, what in the world are you talking about? Like, how does the microbiome have anything to do with anything? I mean, they don't understand it at all. It's like, it's surprising. I talk to patients at major centers, and like I said, I consulted with a patient who's getting her care at MD Anderson, and she's like, "Hey, I get all this of MD Anderson. Nobody's told me anything about the microbiome. Nobody's told me anything." I said, "Well, here's all their studies. These studies came from MD Anderson. The Navy Bean study came from MD Anderson. They have their own microbiome division."
Oops.
So they're doing all the research, but they're not actually getting it to the patients. They're not using it. I mean, really unfortunate. Yeah, I mean, so much of the things, I know we discussed before, like the issues like with acetaminophen, how it, negatively impacts immunotherapies. And, a lot of the doctors don't seem to understand this. It's like, should be, like a, 4-alarm fire here. We got to pull the thing and let's say, hey, all doctors need to know this.
And that's what's great about you, Jason, is you're such a pattern recognizer. I mean, a lot of docs, they're so analytical, which is great, but they're so sequential, right? They're so linear in their thinking. And I think, and this is where I think you and I have some commonality, is that, it's the bigger kind of pattern recognition, and then you're able to pick these pieces that most would not see and bring those and actually bring them into the clinical practice way ahead of the curve. And like you said, you're assimilating data that most don't even know about.
Right. Yeah. I think there was something at the water there in Shreveport that made us super smart.
There'd be a lot of people that probably say that's not the case, the water in Shreveport. But yeah, shout out to those people at LSU Health Science Center. So Shreveport, it was a great time. Definitely. One of the things that I've been looking at, Jason, and after this we'll jump into your first case study, is there was an article looking at pancreatic cancer. And they were actually talking about how the gut microbiome actually seeding pancreatic cancer.
Yes.
So, I mean, not just that there is a tumor microbiome. So people go, gut microbiome, I've never heard of that. But tumor microbiome, meaning we can now probably, there's literature talking about this, identify bacteria as much by the bacteria that's there as the histological or quote unquote, breast cancer and prostate cancer, but by the bacteria that's there. I mean, what's your thoughts on that? Because this is like quantum, it's on a whole nother level.
I mean, I think if you go back in the early 90s when they identified H. pylori for gastric cancer, and at first everybody's like, no, how's bacteria have anything to do with cancer? And then of course those doctors did that and they actually took it themselves and got it right, and then they get it themselves. And so the idea that bacteria can actually be the nidus cause of cancer, I think, is clearly evident. And in pancreas, the pancreas is a digestive organ that's connected to all of this, stuff as far as the intestines and everything else through the bile ducts. The bacteria transgress from those intestines into the pancreas. So the microbiome you have in your intestines also gets into the pancreas. And if that microbiome is bad, then it may promote cancer. And so it does seem to be that there are certain bacteria that get into the pancreas and are promoting that. Now then the question would be, well, so could you treat it with antibiotics? But it's not quite that simple. And once it's sort of formed, then it's going, right. The snowball is already rolling, and so you got to find another way to treat it. But you definitely need to fix the microbiome as a basic foundation.
Yeah, especially for the gastrointestinal cancers, right? I mean, esophageal all the way down, to the rectum. Do you think it has a place even outside of the gastrointestinal cancers?
It does, amazingly, yeah. So amazing, like lung cancer has a huge involvement with the gut microbiome. Breast cancer, recurrence, all that gut microbiome. I mean, it's actually most cancers really have an origin to the microbiome, or at least have some promotion from the microbiome. And it's extremely fascinating that that's the case, and that we definitely have been. I think standard of care has been ignoring this part of the whole thing. I mean, what are they doing? They're just looking at the cancer itself, treating it. What do? They give it a drug. They slam it with a drug.
Yep.
I mean, it's like if you're saying, hey, I'm I'm thirsty. Okay, I'm gonna give you a bottle of water. I'm gonna give you a fire hose,
Yeah, yeah,
and
yeah.
just throw it on you. And so that's a problem. But yeah, I think that we need to be focused a lot more on that and getting all parts to try to get the best chance for these cancer patients to get good results.
Yeah, and that study was actually published in 2019, Tumor Microbiome Diversity and Composition Influencing Pancreatic Cancer Outcomes. So for me, somebody comes in with a diagnosis of pancreatic cancer, Jason, I'm aggressively moving on, the gut flora, fecal
Yeah.
transplant, et cetera. So this is I think a good spot to talk about your first case, because it's the 51-year-old with a pancreatic adenocarcinoma.
Yeah.
So I think
It's
it would be really
amazing.
great here, because what we're going to do in the podcast is you actually send us those images, and that's perfect. We're going to pop those up so that when people are watching it on the video streaming services, they'll be able to see that.
Great.
So if you're listening to the podcast, go check out the video on YouTube or Rumble.
Good, yeah. So yeah, let me pull up because I've got several of the cases here, kind of all in the background, and let me see if I can find that specific
Yeah, because this
one.
is the gentleman with the pancreatic adenocarcinoma that was metastatic to the liver, which unfortunately is something we
Yeah,
see far too often.
yeah, and so you could see on that case where the patient, they've been getting some treatment and they were getting some response, but then they did Rebyota, and there's just sort of drastic shrinkage after Rebyota, just within a couple weeks. Both of the pancreatic lesions and of the liver metastasis in that patient.
Yeah, and you look
And
at the imaging there, Jason. I mean, you've got the arrows showing the drastic reduction in that. Now, when you did the Rebyota, were they only doing the Rebyota transplant here? So they had one transplant, or were they receiving other therapies?
So that patient, what happened was they were getting other therapies, but they weren't really responding well.
Okay.
They were just sort of stagnant.
Yeah.
And then the Rebyota kind of caused things to surge, and then they started getting a response.
Because you had him on the, kind of the Gemzar, which is kind of the, one of the golden tickets, if you
Yeah.
will, for pancreatic cancer. But then you had some other things on board, really trying to elicit an immune response, right?
Yeah, so a lot of these patients are heavily pretreated, and they do Gemzar, durvalumab, and things like
Yeah.
that. So the the reality, in pancreatic cancer is that when you need immunotherapy for it, you need an agent that's called CD40.
Yeah.
CD40 is a real game changer in pancreatic cancer, but it's not FDA approved yet, or I don't know when it'll be. But that drug really makes a big difference. But yeah, that's you those patients. I mean, when they're doing Gemzar, usually they've done full Fox, full Fury. Now they've got the new one, the liposomal irinotecan,
Yeah.
that they're doing as well.
So basically, you were trying to elicit an immune response. Not much was happening. You come in with Rebyota, and you turn on the immune response.
And then you see shrinkage in these patients. It's amazing. Like the patients are progressing, or maybe they're just stagnant. Maybe they're stable or slowly progressing, and then you give them Rebyota, and then all of a sudden now you start to see shrinkage of their cancer. I'm not saying that Rebyota in by itself is enough to do it, but I think it's a big assist. And I think that when you're fighting cancer with chemo and everything else, if you don't have the microbiome working with you, then you're trying to paddle upstream. It's like it's really difficult, and so you need to fix that microbiome to help you.
It seems like the immune system, you're just not going to get the full immune response, or any immune response, without the gut microbiome optimized. And it's interesting.
Yeah.
It's interesting, Jason, because there was a recent article that came out, on ivermectin turning cold tumors hot. And I mean, the same thing could be applied right here, talking about, fecal transplant and the gut microbiome.
Yeah, and and who knows? I wonder, is ivermectin's effect, could it even be on the microbiome? I mean,
I was
maybe
I was setting you up for that because that's what I wonder. That's what I wonder is because we think about it. Oh, it's an anti-parasitic. It's directly targeting cancer, and we think about our treatments. They're going after cancer, but maybe the effects that what we see from our treatments are actually in something that's completely out of our purview. But that in turn is what's happening to the cancer. It's just like what you do with your intratumoral therapies, right? You're getting systemic effects.